Uh, well, basically, the speaking test in OET is profession specific. It means that uh, each profession has their own speaking. So doctors have different one, nurses, dentists, vets, they have different tasks in both speaking and writing. Listening and reading are the same for all professions. In speaking for doctors, the format is the same actually. The tasks are profession specific. But usually there is a warm-up session which is a few minutes. Just they say, okay, hi, what's your name? How are you doing? Uh, what is your profession? Why did you choose to be a doctor? And things like that. And this bit is not assessed because the examiner or the interlocutor is only trying to warm up, basically, to make you feel comfortable.
Yeah.
Then you will have 3 minutes to prepare for a role play. So you will be given a card and you go through that for 3 minutes. You can take notes if you want. And then you have a consultation. And
Yeah.
that consultation is 5 minutes. And this repeats once more. So basically, you have two role plays, and you have 3 minutes to prepare for each one. Okay?
Yeah.
Um, so, uh, the speaking criteria. Well, basically, the speaking criteria is now this, and it's got two sections. And the first part is the linguistic criteria. It means the language, and that is intelligibility, means how well someone can understand you. Fluency, how fluent you can speak. Appropriate language, and resources of grammar and expression. And communication criteria, which is again profession specific, and this is something new, and it's 3 marks each. That's relationship building, understanding and incorporating the patient's perspective, providing a structure, information gathering, and information giving. We will go through these together to see what you actually need to do or what you need to provide.
Yeah.
Well, um linguistic criteria, 6 marks each. Intelligibility, which is um how well a candidate's speech can be heard and understood. So that is pronunciation, rhythm, stress, intonation, pitch, and accent. What are these? Pronunciation, you know. What is rhythm?
Uh, I know.
The rhythm of speech means how fast or how slow you speak.
Oh, yeah.
Okay. If someone speaks too quickly or if somebody speaks too slowly. Okay. Uh, stress.
Uh, I think that is, I know that about the stress for each words. For example, some words have a stress in this first section and the second section, but I don't know this is the same or different things.
It is indeed the same. Yeah.
Yes.
We say candidate. We don't say candidate or candidate. We say candidate. Okay.
Yeah.
Or understood. We don't say understood. We say understood. So, intonation is actually in the sentence where you raise your voice, where you lower your voice, and stress helps a lot with that.
Yeah.
It means that when you're asking a question, you raise your voice and you say, "How are you today?" Or if you're actually giving information, you see, I think the weather is nice today. So this is a falling intonation. So depending on if your voice is going up or down.
Mm-hmm.
The pitch, um, like some people speak very loudly, and some people speak very uh, screamy. Okay, so if you speak loudly or with a different pitch, it means that you're screaming or shouting. Okay, or maybe someone speaks like this, you know. So it means very low pitched. High pitched is when you it's like screaming. Okay, so it's like women's voice. So that's a high pitch. So your pitch needs to be appropriate. You shouldn't be shouting or screaming. Okay,
Yeah.
and the accent needs to be understood. Uh, it doesn't matter if you speak British accent, Australian, American, or whatever accent. It doesn't matter. All that matters is that your accent is appropriate English and it can be understood. Okay? So there is no plus for any specific accent. Right. So the second one is fluency. How well a candidate's speech is delivered in terms of rate and flow of speech. Okay, it means that your speech needs to be even and smooth. What does that mean?
Uh, I think it means of fluent or not.
Yes, but even and smooth, it means continuous and not breaking, okay? Um, no excessive hesitation. Now, some hesitation is normal, like when I say, okay, so it means that I'm thinking. So I might do that on purpose to say that I'm thinking, or maybe to give you space to speak. But if it is um, um, that is excessive, okay? So a little bit of hesitation is normal, but too much of that is abnormal.
Yeah.
Repetition. Uh, some people repeat themselves. They say the words twice. Twice. Okay. Self-correction or fillers. Okay, self-correction. Some people say something wrongly. Okay. And they correct themselves. We don't want that. Not excessively. Fillers. What are fillers?
For example, I know I see is a kind of word or phrases that maybe kill a time and give a opportunity for thinking
That's
how
right.
want
Good.
to progress it.
Excellent. Okay. And some fillers are normal. Like even native speakers sometimes say, you see, sometimes, okay, say that it's a sort of difficult, okay, it's a kind of easy. So, sort of, kind of. As far as I am concerned, or in my opinion, so that is uh, a way of filling the conversation instead of pausing. And if it is too much, if it catches attention, so that is something that has negative effect on your fluency. A good speed, it means normal speed. It means not too slowly. We don't want you to be too fast. And also just normal speed, okay? The way I'm speaking to you. So if you speak more slowly, that might affect your mark. Appropriate pauses, and yeah, that is what I said. Some pauses are appropriate, okay?
Yeah.
So this pause was appropriate because I was giving you space, okay?
Yes.
And next part is appropriate language. How well a candidate uses language, register, and tone that are appropriate to the situation and the patient, okay?
Yes.
And adjustments made to suit patient type and context. Basically, If a patient is happy, you can talk to them with a happy attitude. If the patient is sad, or if you're going to give them bad news, you need to have the same type of attitude, and you need to say something you want to say more slowly, and you take time and you show some empathy.
Yeah.
So you can see that in the news when they give good news, then okay, just a moment. Sorry. Uh, okay. Okay. I silenced it. Okay. So basically, we say that. Where were we? Yep. If the in the news, when they give good news, they are happy. After that, they smile. But if they give bad news, for example, they show the fire in Australia, and they show animals dying and that sort of thing, and then when it finishes, they actually pause and they show a facial expression that they are not very happy. They're sad. Okay, it's the same way. Um, Lay language means the people's language. So we shouldn't use when we're giving information, for example, or when we're asking questions, we shouldn't use medical jargon. Also, professionalism. It means you respect the patient, you act professionally. So, and you speak professionally. You don't use words that are taboo, or they're not ordinary words. Okay.
Yeah.
And difficult patients. Some patients are difficult. They want something, they get angry, they get aggressive, they can shout. So you need to be able to speak to them in the proper tone and proper language. And we might actually talk about that at some point. What kind of patients and how we can deal with them. Resources of grammar and expression is obviously the level of your grammar and vocabulary, which needs to be appropriate. So your range and accuracy, a good range and accurate. Meaning conveyed clearly. It means you can actually say what you mean clearly. Question formation, how you can make questions, and word choice, the choice of the terminology. Okay, that is a linguistic criteria. Any problem with that?
No, thank you so much.
Okay, so that's quite obvious. So we go to the communication criteria. This is fairly new, and it's a part of the updated OET. Is a couple of years or so. Um, so basically, they want to see what your communication skills are like, and each of these has 3 marks, so that is 15 in total. So the other one was 24. This is 15. Okay. So let's see. Relationship building. Well, basically, it means initiating the interaction appropriately with the patient. Greeting, introduction, that is introducing yourself if necessary. Nature of the interview, you say why we are having this interview, or why we are having this consultation. Establish rapport. What is rapport?
I don't know.
Rapport means it's a French word. It means connection and cooperation, okay, or a cooperative relationship. So it means connecting to the patient and to start a cooperation together, okay.
Yeah.
So basically, for these you will get marks. Demonstrating an attentive and respectful attitude. So Attentive? What is attentive?
Sorry, I don't know.
It means paying attention, okay,
Oh,
and respectful. So establishes trust and patience, puts patient at comfort. So basically, if you listen to the patient well and you are respectful, the patient starts to trust you, and the patient feels comfortable. And then you ask permission or consent, uh, or you are sensitive to embarrassing matters. Okay, I'll give you an example. If you want to ask a woman or a lady whether they're married or not, or if you want to ask if they are sexually active, you can't just ask it. You need to ask for permission, or you might say, "Well, I understand this might be uncomfortable, but could I ask you a personal question?" Okay, so actually you show some sensitivity. You can't just ask, "Okay, are you sexually active?" No, that's wrong. Okay, so you need to be sensitive, or mm, basically, uh, even for contraceptive pill, uh, y- if there is a young lady, I don't know, 16, 17, you want to ask them if they take contraceptive pill, you need to say, well, can I ask you a personal question? I know it might be embarrassing, but I need to ask you this. I say, okay, go ahead and say, yeah, did you take any contraceptive pills or do you use any contraception? And so that is the correct way of saying sensitive questions. Okay, so that is respectful. And what is attentive?
pay attention.
Paying attention. So it means that you need to show the patient that you are paying attention to what they're saying. We will talk about it later in information gathering.
Yeah.
Next is, oh, and the same relationship building, adopting a non-judgmental approach. Accepting patient views, acknowledging legitimacy of the patient to have their views or feeling. What is legitimacy?
Sorry, I don't know.
Legitimate means it is reasonable. It is they have the right to have their own views and feelings. So we don't make fun of them. We don't judge them. Okay, we accept the patient's views. And what does it mean? I mean, eh, I had a candidate who said, I went for the test, and my first patient or my first card was a patient who thought they've got some uh, fish bone in their throat for 1 year.
Okay.
And ha ha ha, isn't that ridiculous? So, okay, so this means that you are judging that person, and this is wrong because you need to be non-judgmental. So even if something you think is funny, you shouldn't actually do that because that's your personal opinion. So you need to look at the patient very objectively. You shouldn't judge them. So there might be something else, but that is what they think. That is their view. So we shouldn't judge them. Okay?
Yes, I know.
Showing empathy for feelings, predicament, emotional states. Now, showing empathy means you show that you understand them and you say that. Okay, so showing empathy has two parts. Basically, understanding the patient and communicating that understanding back to them. Okay, so um, if you just say, "Oh, I'm sorry," that means you are showing empathy. For example, if you say, "Oh, sorry to hear that. I know it can be difficult." Okay, so this means you say that you understand their feeling or their emotional state or predicament, and you say you're sorry. It can be verbal or non-verbal. Now, uh, verbal means you say it, and that's what we want in OET exam. Okay, because you are being recorded, but they cannot see you. So even if you show nonverbal empathy, it means even if you pause or with facial expression or with your basically with your manners you show empathy, it doesn't count in the exam because they cannot see you. Okay,
Okay.
so it's better to say it verbally. Okay. The next is understanding and incorporating the patient's perspective. Well, it means eliciting, means taking out, extracting, and exploring patients' ideas, concerns, expectations. ICE. Have you heard of that?
No.
ICE. Okay, you will hear a lot about ICE.
Nice.
Uh, you will have ICE until the day you retire. So basically, they say when the patient comes to you, they have a problem. Okay, and this problem is either an idea they have, they think something, or they have a worry or concern, or they want something, they have an expectation. Okay, and that's what we need to find. We need to know what is the patient's idea, what they're worried about, and what they want. Okay.
Yeah.
So it means we need to find out patient's perspective of illness or concerns. What does the patient think about the illness, or what are they worried about? Even sometimes asking directly or encourage them for elaboration. For elaboration means explaining more. Uh, Most of the time, the patient comes to you and said, "Well, doctor, I've had a sore throat for 2 days, and this sore throat doesn't get any better with painkillers. And so I was thinking maybe I should need some antibiotics." Okay, so what is the patient's idea, concern, or expectation?
Uh, just wanted a prescription of antibiotic.
Okay, so I have had this sore throat for 2 days. It doesn't get better with painkillers. So I thought maybe I need antibiotics. So the idea is that he or she needs antibiotics, and expectation antibiotics. Okay, and
Yes.
then you explore this. You ask more. You say, okay, what do you mean? And can I ask you more questions? And you ask more questions. Okay. Sometimes the patient doesn't tell you, or sometimes the patient has another idea, concern, expectation that just mentions it. We call these cues. Okay, picking up patient cues, like some cues are hesitation, pauses, change in volume of the speech. Okay, so I give you an example. Uh, all right, doctor. Hello, how are you? Well, I've just had this pain in the middle of my chest for the last 3 days, and I just thought I should come and have it checked because one of my friends had a heart attack a few months ago, so I thought I would come and ask you to have a look at me. So, what is the patient's idea, concern, or expectation?
I'm sure that is not related only to about chest pain or etc. But so I don't know.
Okay, so I have chest pain for 3 days, and I thought I should come and have it checked. So this is the thinking. Okay, he thinks that this needs to be checked. Okay, and then why mentions that's a cue. One of my friends had a heart attack a few months ago.
Oh,
Okay,
concern about these events for him
that's
or
right, exactly. So he's concerned about a heart attack. Okay, so although he doesn't tell you directly, he is concerned with heart attack. Okay? That is a cue. Or maybe you have seen people who come to you and say, well, I've had diarrhea for a few days and I feel so dry and I cannot drink anything. I was thinking maybe you can give me something to help. Okay. What do they want?
I think that this concern about giving any prescription because they they said that I need anything. No.
The patient says, I can't drink anything. So I was thinking maybe you can give me something.
Or maybe
I,
need food or drinks.
okay. Or maybe they're asking for an IV injection or IV fluids.
Oh.
Okay. No. Anyway, okay. So yeah. So if somebody comes and says, "Oh, well, I have sore throat, and so I've come to see you today." Okay. So you've got sore throat. What? Why are you here today? So you need to establish what they want. What is their ideas, concerns, expectations. And I will tell you later why this is important, because we need to relate this to the information we're giving later. Echoing patient's concerns or encouraging elaboration. Okay, when the patient is talking, you say, okay, all right, okay, I see. The patient says, well, I've had a chest pain for 3 days. Oh, 3 days, okay. Chest pain, 3 days, okay. So it means that you're listening. This is called echoing. So the patient says, yeah, I've had chest pain for 3 days. Okay, oh, chest pain 3 days. Oh, your friend had heart attack. So this means you're listening and you're listening attentively. And later you relate the eyes to your explanation later. You say later, for example, you mentioned earlier that you were concerned that you might have angina. I can see why you might have thought that, but I don't think it is angina. Okay. You can say later, so you've had this chest pain, and I understand that because your friend had heart attack, you're concerned with heart attack, but yours is different. Okay. So you actually relate to the patient's eyes later.
Later.
So providing a structure. Now basically you need to manage the consultation. And you see you have 5 minutes. So basically 1 or 2 minutes you have this part, and then 1 or 2 minutes you need to give information. So you cannot just let the patient go on their own. You need to make sure you have this structure that you ask question first. Okay, first of all you connect, then you ask questions. After you ask questions, you probably summarize and say what you have heard, and then come up with a diagnosis, and then start giving information. And in each part, we need to actually inform the patient or give them a sign. We call it signposting.
Yeah.
Give you an example. So it says sequencing the interview purposefully and logically. It helps efficient data gathering and giving. Need to balance with patient-centered approach. Right. Well, if you talk too much, the patient doesn't speak, so it's a doctor-centered approach.
Okay.
But we need a balance. We need to give the patient space as well. Usually uh, the role players are instructed not to speak too much, okay? So they wouldn't go on and on unless it is the scenario. Having said that, I think that is beyond your level of this examination. So this is probably beyond the scope of the exam. You might have that later in more professional exams like PLAB or OSCEs. But at this point, I don't think role players speak too much. So, signposting changes in topic. So you ask questions. You say, okay, so you said that you have this chest pain for 3 days, and it doesn't get any better with painkillers. Is that right? And they say yes. I say, okay, and you said that your friend had a heart attack, so you're worried about heart attack. Is that right? Yes. Okay. So let me examine you. Now, this let me examine you is signpost. Or if I say, okay, let me ask you some more questions. Is that okay? Or I need to ask you some more questions. Is that okay? So this is signposting. You're explaining to the patient that what I'm going to do next is to ask more questions or to examine you. After you examine the patient, okay, let me talk to you about my opinion. What I think is that your pain is not related to your heart, okay? So this is signposting. You are actually telling the patient, the questioning finished, examination finished, I'm going to talk to you about diagnosis. Now, let's see what we can do for you. This means that I'm going to talk to you about treatment options. So these are called signposting. Uh, these give a structure to the consultation. So if you actually do this, if the different parts of the consultation can be identified easily, it means that you get your full mark on this. Um, signposting is used to progress from one section to another and explain the reason for progression. So you explain why you're going. Is that okay? Is there any problem with here?
No, 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 no.
Good. Um, using organizing techniques in explanations. Okay. So when you're explaining, when you're giving information, you organize things. For example, categorization, forewarning of categories about to be provided. So, for example, you say, okay, now I want to talk to you about the causes of chest pain. All right. So the causes of chest pain. Labeling means emphasizing the important points, like it is important that you do this and that, okay? Or it's not important that, okay? This is labeling something which is important or not important. Chunking, it means clear gaps in information categories. Basically, it means that we don't actually give a lecture to the patient. We say, okay, I'm going to talk to you about chest pain, different types of chest pain. Is that okay? They say, okay. So this is the first part. You pause. And then you say, okay, some pains are caused by heart. And these are usually the ones that get worse with walking or with exertion or with doing exercises. Is that okay? I say okay. So that's first part. Some other pains are because of the muscles and bones in the chest. And these are the ones that when we press they hurt. Is that okay? So yes, okay. Right? So you pause between these and you check. So you don't actually carry on saying that, okay, there are different types of chest pain. Some of them are cardiac chest pain, some of them are chest wall pain, some of them are due to a stomach problem, some of them are because of lungs, and no, we don't want that. Okay, and repetition and summary. So when you finished your chunking and checking, you say, okay, these are the different types of pain, chest pain, and I should say that I don't think your pain is because of your heart. It sounds to me like that it is the pain in the bones and muscles. Okay, so that summarizes. facilitating patient's narrative, active listening, minimal interruption. So basically this says when the patient is talking at the beginning of the consultation, don't interrupt them. Just just be quiet and pause or say, okay, I see, and echoing a repetition, okay, right, chest pain 3 days, okay. Paraphrasing and interpretation. And sometimes you say this back to the patient. You say, so you mean that the chest pain was always there. It was constant. It didn't come and go. And they say yes. Okay. Um, so using initially open questions appropriately, moving to closed questions. Right. You know, these are checklists and they mark you based on these. So what does this mean? This is the same thing we normally do. Okay. There's a big difference between doctors who actually ask enough questions and doctors who actually start to ask closed questions too early. Now, let me tell you something. I say, okay, doctor, I have I've had this chest pain for 3 days. Okay. Um, what do you ask me first?
Let me explain more about this.
Let me ask you more.
Yeah.
Yeah. You want to ask more questions. What do you ask?
Uh, I think that for the first question is better to say to patient that please more explain about your pain.
Good. Please, could you explain more? And I say, yes, this pain is in the middle of my chest, and it is more than discomfort. It hurts actually, and I took some paracetamol, but it didn't actually get better. Okay. Now, what do you ask next?
Uh, I think that is better about ask about the pictures of pain and how many tablets take it. Or
Okay. Okay. Good. So we explore further. But how do we explore with WH questions? What are WH questions?
started with what, which, where,
Okay.
and
Good. So basically, we say, okay. So you said it's in the middle of your chest. Is that right? Yes. Okay. And you said that it started 3 days ago. And so, how bad was it? How severe was it from 0 to 10? And so, where exactly is it? Just in the middle of the chest, or is it anywhere else? And now, after you ask these WH questions, then you go to fill in the gaps and you say, did you have any other symptoms? This is the yes no question. Okay. Did you have any other symptoms? Yes. What was it? Stomach pain. Okay. Did it go anywhere? Yes, it went to my back. Okay. Um, so uh, basically, you ask closed questions to fill in the gaps that you need to make a decision. So you need to establish what kind of chest pain it was. At first, you start with WH questions, with open questions. Then you fill in the gaps with the questions that you need, whether it radiates, does it come and go, or is it always there? We don't say or, we say, does it come and go? Um, does it go anywhere in your body? Did you have any other symptoms with it? So basically, these are the filling the gaps, the closed questions. Is that okay?
yes.
Okay. Not using compound or leading questions. Okay. We don't say, when you say this, do you mean this? Oh, yes, we say this. We don't say, we don't ask two questions at the same time. Okay. If you ask two questions at the same time, the patient is confused. They don't know which one to answer. Okay. So if I say, did it go anywhere in your body, or Did it come and go? So the patient needs to think, okay, which one should I answer first? And maybe they just answer one of them or not at all. So, and questions with assumptions which are hard to contradict. You say, so um, so you must have had a very severe pain. Is that right? You're making an assumption, and he says yes. Okay, that's most people say yes, but maybe it's not very severe pain. It's just maybe 3 out of 10. But when you say it, they say yes. So don't make assumptions.
Okay.
Clarifying statements which are vague or need amplification. If you don't understand something, or if something is important, you can ask. You say, may I ask you what you mean by not severe or very severe? What in the score of 0 to 10 is your pain like? And they say, okay, it's a 4. Okay, so you can ask for clarification. May I ask you what you mean by this? Or when you say severe, do you mean something like 4 or 8? And they say no, I'm something like 8, like 4. Yes. Okay. Summarizing information to encourage correction, invite further information. This is so important. Okay. I would like you to try to use this in all your consultations. What is summarizing?
I think that the end of conversation is better to summarize for the patients what's happening and know what to do the patients.
Mm-hmm. Mm. Um, okay, not necessarily at the end, but I mean, you can summarize anywhere in your consultation. Um, if you feel you're lost, I mean, sometimes you need to ask more questions, but you cannot remember. Okay, you can summarize. Then you will have some time, and sometimes the patient helps you. They add some information. Okay, so when you summarize, you buy yourself some time. Also, you give the patient the opportunity to give you more information or to correct you if you have made a mistake. It also tells the patient and the examiner that you have been listening attentively, so it serves a lot of purposes. Um, I did a sample summarizing. I said, so you have this pain, this chest pain for the last 3 days, and it was in the middle of your chest, and also you're worried because your friend had a heart attack 3 months ago. Is that right?
Uh-huh.
Yes, yes, that's right. And oh, yes, by the way, my stomach was also hurting. So even if I don't ask it, the patient remembers something and say, "Oh, my stomach was also hurting." Okay, so your stomach was also hurting. So this is summarizing. So this gives me some time to think, gives the patient the opportunity to add or to correct. Okay. Uh, Also, it gives a structure to the consultation. Basically, after you finish with gathering your information, you summarize everything and you say, okay, let me see if I've got it right. So you mean you had this chest pain for the last 3 days and it doesn't come and go, it's always there, goes to your back and your stomach, and it hurts when you press on it. Is that right? And it says, yes, that's right. Okay. And you said that you're worried about your heart attack because your friend had a heart attack 3 months ago. Is that right? Yes, that's right. Okay. Let me examine you and then I will tell you what I think it is. Is that okay? All right. Okay. All right. Now that I have examined you, everything seems to be normal. And in my opinion, your pain is because of the bone and muscle pain, and it doesn't have it is very unlikely to be anything related to your heart. Okay? So basically, you summarize, you examine, and then now you say, well, based on what you said, the examination is normal. Therefore, I think that, in my opinion, it is uh, chest wall pain. Okay. So you see, the summarizing helps you with signposting as well, because basically, when you summarize, you know you need to stop here and do something else or ask more questions. Okay.
Okay.
Information giving. Right, that's usually the last part of the consultation. When you have gathered enough information when you understand patients' ideas, concerns, expectations, you make a diagnosis. Now you're giving information. Okay. Usually, we say you initially need to establish what the patient already knows and assess their prior knowledge. Then determine what information to give and how to give it. And this is something a lot of people miss. And even myself, I sometimes miss it. Sometimes you start explaining, forgetting that the person who's sitting in front of you, the patient, knows all of this, and you're actually explaining the obvious. I sometimes go to my doctor and they start explaining things in lay language, and I say, okay, doctor, let me tell you, I'm a doctor myself, so just tell me. Okay. So the first thing actually is to say to the patient, okay, what do you think it is, or how much do you know about this, or how much would you like to know? Um,
Or
you can
have
you,
you ever heard about this?
Yeah, you can say, well, how much do you know and how much would you like to know? So
Okay.
that's a very easy question. Right, I think it's pain in the muscles and bones in the chest. So how much do you know about this and how much would you like to know? And they say, well, I know that this means that it hasn't got anything to do with my heart. But could you tell me how we can make sure it's not my heart? How can we definitely say it's not my heart? So basically, you need to start from here and say, okay, so you don't need to explain chest wall pain or the causes. You just go on, okay, so you want to know how we can say it's not heart. And this is because the description of the pain doesn't fit in, but still we can do a blood test, and that is a definite diagnosis. Um, okay.
Yeah.
So first we establish what the patient knows and then start to give the information. Pausing periodically when giving information, using response to guide next steps, like chunking and checking, where I was saying to you, between categories or between different parts of the information giving, you pause and check. So I say, okay, yeah, heart pain is like this. It gets worse with exercise. Is that okay? And so, okay, right. But this kind of pain that you have, because it doesn't change with exercise, it's very unlikely to be a heart pain. Is that all right? Okay. So you go to the next part. So basically, you give a chunk of information, maybe one, two, or three sentences, and then you check with them. Okay. And use the patient interaction to determine what information to supply next. So if the patient says, yes, I understand, I would say, no, actually, I don't understand why you're saying that. So you need to give more information about the previous matter. Okay?
Okay.
Encourage the patient to contribute with reactions and feelings. So you tell them, okay, the patient might say, well, how do I know it's not my heart? You're saying this is a chest wall pain, but how do I know? Can you clarify that? You say, yes, okay, yeah, I understand what you're worried about that. But yes, we can do a blood test. It's not typical chest pain. It's very unlikely to be problem, but we can do a blood test. Okay? And then at the end, you check whether the patient has understood the information. They usually say, don't say, does it make sense? Does it make sense? It means um, it means, do you understand it? And if you say this to anyone, they say, oh, of course I understand it. I'm not stupid. Okay. Uh, we usually say this. I know, I understand it's a lot to take in one go, or I know it's a lot of information, but I just want to see, just want to make sure that we're in the same boat or we're on the same page. Um, so how much do you remember what I said, or how much did you, uh, or would you mind repeating what I said? Okay. So basically, you show that you don't want to test them. You just say, "Well, I know it's a lot to remember, but I just want to make sure how much you remember, and to just to make sure that we are on the same page." Okay. So that's checking. The patient starts to say what they remember. All right. So there is a stronger focus on communication skills, and there are more clearly defined communication skill requirements. And the skills needed in the healthcare workplace are tested, and they are more profession specific. And there is perceived reduction in focus on linguistic skills. Okay, so the linguistic skills have less mark now, and there's more weight given to the communication skills. And these communication skills are the ones that we have to work on. Now, in terms of your linguistic abilities,